Good evening, everyone. I just wanted to go over this quick paper that was published today, December 14th, 2021. And it is an important paper because there has been a lot of talk about myocarditis and the vaccines. And there is definitely an association between the vaccines and myocarditis. And this is a large paper looking at a huge data set to look at this. And so there's been sporadic reports, but this looked at a very large data set. And so this is really good data on myocarditis. So what they're saying here is in their introduction, they said, 6.3 billion doses of COVID-19 vaccines have been administered worldwide. Clinical trials of COVID-19 vaccines were underpowered to detect the rare adverse events that are important for risk-benefit evaluations and to inform clinical practice and public health policy. So, if you guys remember when Pfizer and Moderna were doing their phase 3 clinical trials for their vaccines, they had about 40 to 50,000 people in their trials. So that's an extremely large trial. But if there's a rare event that happens like 1 in 100,000 people or something like that, you're not going to pick it up in a trial of 50,000 people. But when you start giving doses of like billions of doses of a vaccine, even these rare events are going to show up. And so, how rare are these events and how often do they occur? Those are important things to know to determine are vaccines worth the risk? Is the benefit of the vaccine worth the risk of some complications? Because vaccines, again, are not a zero risk proposition. They have to be very safe because you're essentially using vaccines on healthy people. All right. So the way they did it is the beauty of the UK system is that they have nationalized healthcare and they have a database. So everyone has a medical record number in their whole country that is linked to their medical system. And they know in the UK who's been vaccinated and with what vaccine, and they know if they've been admitted to the hospital and for what they were admitted to the hospital for. So what they did is they looked at all the vaccines that they've gotten. So they had 38,615,491 adults that have been vaccinated with at least one dose of the Chad-Ox. This is the Oxford vaccine, BioNTech vaccine, and the Moderna vaccine. So obviously the Moderna is the smallest number, only 1 million people got it, and 17 million people got Pfizer, and 21 million people got, I believe this is the AstraZeneca vaccine. So they looked at that, and here's the first figure that we need to look at. This is the incidence relative risk. So what they do is they compare the incidence of myocarditis in this population that had these vaccines or got diagnosed with COVID. So they're comparing the incidence in vaccines or COVID to people that haven't had the vaccines and haven't had COVID. So, when you just look at any 38 million people, some of them are going to have myocarditis for, whatever reason, for other reasons that are not related to the intervention you're looking at. So you need to kind of compare it relative to that. So what you see here is, and then this right here is time after the intervention. So this is in the first 7 days. This is in the next week. This is the third week, and this is the fourth week. So first, second, third week, and fourth week after vaccination. What you see in the AstraZeneca vaccine, there is a slight increase in the first week, and then it goes back to baseline. This line right here represents the baseline. This is the baseline rate of myocarditis. And then in pericarditis and cardiac arrhythmias, it actually seems protective, like the vaccine gives you less pericarditis and less cardiac arrhythmias. Here you go, myocarditis in the Pfizer vaccine is not significant, and then after the second dose, there is a blip in the first week, so an increase in the first week. And then pericarditis, again, seems to be somewhat, you get less pericarditis with the vaccine, which doesn't really make sense, actually. It's a small effect. And then with the Moderna vaccine, you see there is a fairly large jump after the first dose and a slightly larger jump at the second dose. And then a little increase in cardiac arrhythmias with the Moderna vaccine after the second dose. And then you see if you actually get COVID, you get myocarditis, pericarditis, and cardiac arrhythmias. They're significantly increased after if you actually get COVID. The other money chart is right here at the bottom. Okay, this is excess events due to exposure per 1 million people exposed. So if you expose 1 million people to the first dose of AstraZeneca or the second dose or BioNTech or Moderna, how much more myocarditis would you expect? So in myocarditis across their whole study population, you see about 7 to 10 excess events due to Moderna in myocarditis. If you get COVID, you'll have 40. So definitely your risk of getting myocarditis is much higher than with COVID with actually getting COVID, the disease, than with getting the vaccine. And the vaccine that is the highest risk is Moderna. Moderna has the highest risk of myocarditis, followed by BioNTech, followed by AstraZeneca. Now, if you subgroup that to young people under the age of 40, it's very interesting, is what you get is their rate of myocarditis with COVID is 10 per million. And their rate with the second dose of Moderna is 15 per million. So actually, in young people, the risk of myocarditis is higher with a Moderna vaccination than with actual COVID. And then Pfizer is a little bit less down here. And then, of course, the risk of pericarditis and cardiac arrhythmia much higher with COVID and essentially zero or kind of protective with the vaccines, and zero with cardiac arrhythmia, other than the second dose of Moderna, which gives a very, very small increase. Okay. So I think this is a really great data set. They looked at 38 million people, so that's a lot of people. So pretty robust data. And what it shows is there's definitely a myocarditis risk, especially with the Moderna vaccine. But it is much lower in the overall population than getting COVID. The one time that the myocarditis effect is worse in vaccination is with Moderna in the under 40 age group. Now, this doesn't take into account all the other possible bad things that happen with COVID. It's not myocarditis. Myocarditis is not the major bad thing that happens with COVID. It's more like pneumonia and blood clots and things like that. Cardiac arrhythmias. Those are much bigger events. You can see the excess events here are in the thousands. Excess events here are in tens. So these are much more common effects. But in this very rare effect, yes, Moderna vaccination in a younger age group is worse than COVID, actual COVID disease. However, if you look across all the other complications, obviously COVID is worse. These are just the cardiac things, pericarditis, cardiac arrhythmia. Obviously having COVID is worse. And then if you look into like pneumonia, clots, those kinds of things, obviously COVID is worse than the vaccine. But this is important data to know that there is a myocarditis risk, especially in younger people with Moderna, and that is something that should be taken into consideration in the risk-benefit analysis of vaccinations, especially given that we're planning on giving boosters to young people. At some point, repeated boosters may, and a prolonged exposure to this increased myocarditis risk may tip the scales, especially in younger people, to, it's just something to think about, to see if that's worthwhile in terms of myocarditis. Now, you can't focus on just this. You got to think about all the other things too. But a good data set, it's hard to get large data sets like this, so it's a very important paper. All right, thanks for watching.